Rain, and good to be in person with you all. So this is the Health Planning Council meeting. We meet once a month. And I think it's every 2-3 months we're in person together. We have lots of guests in the room, so glad that you're here. Welcome. And before, I have to remind you to get the sign in. Thank you. Yeah. So first, we're going to just approve the March minutes. Does anybody have any? Oh, sorry. I asked about. I have a motion to approve the March minutes.
Move them.
Thank you, Frank. Anyone second it? I'll second it. Thank you, Jan. Are there any objections to the March minutes? And they're up here in case you need one. Okay. All in favor? Anyone opposed? Any abstentions? All right, minutes are approved. We're going to move into announcements for the next 15 minutes or so. And then the highlight of our meeting is our 4 panelists that we have here today. So starting with Nicole or John, any committee updates? And welcome to the Zoom folks. Nice to see you all.
So I'll get started just with that. So committee updates, if I could borrow your agenda here so I can see. On the back of your, I think it's the second page on your agenda. So we have our next long-term care committee meeting August 2nd at noon. Right? Okay, I'll let Karen say a couple of things about that. And we just had a really great meeting, so I'll let Karen do those updates. Our next Tough Stuff subcommittee is June 6th, and then Community Health and Access is June 7th at noon, which hoping we can possibly have a continuation from our last Community Health and Access committee meeting, which was a community visioning led by Stevenson County Full Health. I also wanted to make mention, some of us here were at the New York State Public Health Partnership Conference in Saratoga Springs. And next year they announced it's going to be here in Ithaca. So I think it'll be a really great opportunity for local folks that maybe didn't want to like travel out of town to present on issues. So make sure to keep an eye. If you're not already subscribed, I can make sure to share it with Health Planning Council when they announce abstract request so that you can present. I know myself and Meredith Titterton from Cuba Health, we presented on what was initially a pilot project between Cuba Health and HPC, which eventually became the Community Health and Resource Network. So that was really well received at the conference. And on that note too, I wanted to just make an update on our Community Health and Resource Network. And John, feel free to chime in here as well. So those who are familiar, Alex Moore is the HSC project manager who is now out on maternity leave till the end of July. Which was perfect timing because now we kind of shifted from like the HSC really heavy phase of being the partnerships with the CBOs that are cohort 1 in that really development stage of going through and thinking about governance and data and how are we going to communicate this type of project to our community members so that they'll want to be referred on this platform. And now we've moved on to what we're calling phase 1B, which is going to take place over the next few months, which is going to be really onboarding all the community partners onto the PTREFS platform. And then we're going to test the platform and then go live. And at that point, we'll continue having meetings to think about what we need to make tweaks on and messaging and have a website out and brochures and all that great stuff. So that is still happening, but now it's a little bit more Cuba Health led at the moment because we're really focusing on the platform at the moment. John, did you have anything? Did I capture it all? Okay, great. I think that's all. And then Karen, I'll let you add what you want with long-term care and Tough Stuff.
So we met on Friday. We had people both in person and on Zoom, and what we discussed a little bit was a survey that we put out to the members and the guests because one thing that I realized when I started to try to do the emails and updates is I couldn't tell quite who was a member of the committee and who was a guest, because the nice thing that we've been doing in the past is opening up the presentations to the community and getting them in. So what we're trying to do in the long-term care committee is get back to having a solid set of members of who we know that's working on that, as well as we're going to divvy up into some work groups. So we'll continue to meet quarterly. And little subcommittees will report back quarterly on what we're working on. But we surveyed, what are the priority areas that we want to work on? And I think it's important for us to feel like there's some tangible things that we can accomplish and work on. Because otherwise sometimes you get into the committees and you talk about it and talk about it and talk about it. But so we worked on how we might move the needle a little. But we still want to commit to having presenters. So the tough stuff will continue to have presenters that will focus on some of the topics that we're working on, but we will be looking at the end of life issues again and looking at getting a subgroup together that's going to work on maybe getting one of the events once a year going again. We have the home health aid recognition that subgroup will also work on planning and getting that together. Ageism and aging is another subgroup that we're looking at. And the other one is slipping my mind, but I do have the minutes that we'll submit for that. But it was a nice meeting, I think, and it felt like we got some momentum going, but I am going to continue to put the survey out so that, as well as if there are people on the Health Planning Council that want to take the survey. And also the other thing we did is we surveyed who's on our group and what the strengths are, so that we can look and see, are there people we need to recruit to have around the table? Because if we don't have the right people on the committee, we might not be able to address some of those issues. So if there's somebody that you think should be on the committee, let me know. The other thing that we realize is that people come and go. And so it's sometimes we might not know that somebody in an organization needs to be invited to join us. So I could be too long-winded on that. Oh, I have one other community announcement that I can make it real quick, is that there is a free virtual rural health conference on Friday that is Let's Talk About Health, Caring for Older Adults. If you need continuing education credits, it's only $10 to attend. If not, it's free. And it's virtual, so you can come and go to the different sessions that actively appeal to you. It's a great opportunity. We got some good speakers.
I think we have Sam on deck next for a chip update.
Sure, so we're moving down the plan, are getting this next cycle up and running. So it's been a lot of time on planning that the steering committee has been putting in, which I really appreciate, and just wanted to quickly run through who is part of this active steering committee. So it's some staff from Whole Health, from Office for the Aging, Cooperative Extension, Cornell NPH, YMCA, Human Services Coalition here, Food Bank, Southern Tier, Pega Health, County Youth Services, and then representation from TC3 Food Pantry and Wellness Services on TC3's campus. So I just really appreciate all their commitment to these planning meetings, and we're sort of getting some of the structure in place for work groups, and then moving into the next phase of this process, which really will be more community engagement and doing these assessments within to learn more about our community and us towards the priorities for as a whole. So we are wrapping up our community visioning data collections. We've had 2 events, one in person and one virtual. And then there's one out in the lobby, but there's smaller ones here that we've had these community visioning boards located in some different settings around the community, and we've taken them to different community events over the past couple weeks. So I would encourage you, if you have an extra minute, when you leave and go into the lobby, there are sticky notes, and if you'd like to answer the two questions, that would be great. One is, who is in our community? And the other is, if in 5 years our achieve health equity, what would be different, or what would it look like? So if you have thoughts on that and want to add to the board out in the lobby, that would be great. And we're wrapping that up so that the information that people have contributed can be, like, themes can be pulled out, and we can make a vision statement for the rest of the process. More to come.
Thank you, Sam. And I want to just quickly check in with our friends on Zoom. How's the volume by you? I get a thumbs, okay, thank you, Norm. I'm not quite sure why the camera is just directed at over here instead of, does anybody from Whole Health know how to adjust that?
It's not moving on its own.
Oh, I see, okay.
When the panels part starts, let's keep it over there. Yeah. Working on them, but I apologize to those online that it's not moving on its own. So I try to operate it like a video game. So we'll zoom in. Yes, when you guys are presenting.
Thank you. All right, so now we're just gonna open it up to board members, HSC staff, our guests. If you have any announcements that you would like to make, program updates, workshops.
We have a webinar, our monthly telephone teach-in with our patients advocates program. And so if you work with seniors, caregivers, or people with disabilities, this is a good one because it's a conversation with Rhonda Schwartz. She's the regional administrator for the Administration on Community Living for our region. So I printed out some flyers. Oh, Stefan, you're from statewide. I'll pass them around. If you think it applies, please feel free to take one.
Thank you, Stefania. Other updates? Where's Shasta? You always have something.
I'm letting other folks go first. So we have our board chair roundtable that's coming up tomorrow, actually, it's indeed will pass. And that will be from 3 to 5 at the Tioga Place TC3 Extension Center on the 6th floor. We also have a board boot camp for any of your boards, or if you serve on a board and would like a refresher. You know, folks who are interested in joining boards but aren't sure kind of what that looks like. Our boot camp is a great place to start, and that's on the 23rd from 3 to 5 at Tioga Place. And then we also do have a nonprofit budget and finance basics coming up. It has been rescheduled, so you might see some things floating around stating that it's on the 11th. It's actually on the 10th, so that's a couple of Mondays, the second Monday in June. And that'll be at the library.
Thank you, Shasta. Right. Oh, thanks, Liza. Go ahead.
I just wanted to mention that Lifelong is hiring a new HICAP coordinator, the person who coordinates Tompkins County's Medicare program. We also have Medicare counselors through the Office for the Aging. This person oversees the program. It's a part-time 20-hour-a-week position, helping people navigate their Medicare coverage and save on costs and co-pays and all that good stuff. So please send anybody our way if they may be interested.
Thank you, Liza. Is there anyone else on Zoom who would like to make an announcement? In the room? All right, well then we are going to shift into our the panel portion of today's meeting. We have a little over an hour for this discussion, which I'm super excited for. I'll start by introducing our panelists. Then I'll spend about 40 minutes with questions that we have pre-given the panelists. And then we'll aim for about 20 minutes for you all to be able to ask questions. So I'll start with introductions, starting with Samantha. Samantha Stevenson is the Director of Operations at Reach Medical. Samantha has been with Reach since opening in 2018. Samantha has over 2 decades of public health experience, both in direct care and administrative roles. Great to have you here. Then we have Rich Shaw. Rich has worked at Tompkins County Whole Health for 15 years in the role of Coordinator of Dual Recovery Services. This position was created by a collaboration between the Offices of Mental Health and Addiction Services and Supports to better serve people with co-occurring substance use and mental health issues by providing consultation and training to local service providers and by promoting coordination between treatment agencies. He has delivered direct treatment in state licensed mental health and substance use clinics for over 30 years, including supervision of intensive outpatient treatment and outpatient rehabilitation programs. In Tompkins County, he also serves as coordinator of the Assisted Outpatient Treatment Program and the Single Point of Entry. Good to have you here, Rich. And then we have Dr. Alecia Sundsmo. Dr. Sundsmo is a clinical psychologist by training who has spent the majority of her career directing counseling and psychiatric services for college students. Throughout her 16-year career, she has focused on service delivery models that utilize a public health lens, always striving to maximize the impact of care delivery to do the greatest good in the community. No matter whether she's working with 1,600 students at a small liberal arts college or 43,000 students at a flagship state university, she focused her efforts on access to care, guiding students to the right level to meet their needs, and supporting the community around them to build environments where students can thrive. She joined Family and Children's Service of Ithaca in the fall of 2023 as the Director of Clinical Services and is on a steep learning curve about this new regulatory environment, but remains excited to bring the skills learned in her career thus far to continue to invest in bettering the mental health of our community. Thank you, Dr. Sundsmo. And lastly, we have Jacob Parker Carver, the Alcohol and Drug Services Coordinator / Counselor and Therapist at Cornell Health. Jacob has taught ESL in China for almost 5 years following completing his undergraduate education. He completed his MSW at Binghamton University and worked as a crisis counselor for suicide prevention and crisis services. Following graduation, he worked as a chemical dependency clinician at the Alcohol and Drug Council before coming to Cornell Health in 2021. He enjoys social justice warrior work and has traveled to 17 countries and enjoys sipping tea at the Alley Cat Cafe and kayaking on Cayuga Lake. And I heard it has since adopted 2 cats and therefore spends less time at the Alley Cat. Right. Oh, sorry. Jasmin. Online. Oh, Jasmin is online. Sorry. Hi, Jasmin. Thank you for joining us online. Jasmin Sutton has worked for apologies.
It's okay.
For CARS for 4 years. She started out at the residence before transitioning to the outpatient clinic. She has her bachelor's in psychology and her KSAC 2 licensure. Currently, her job is a primary addiction counselor. She thinks everyone can relate with knowing someone who has been impacted by substance use, and CARS strives to help clients accomplish their goals while living a healthy lifestyle. Thank you for joining us, Jasmin. Okay, so let's dive into our questions. So the first question, and I'll try to change it up. We'll start with Jacob. Please give a brief overview of the types of services and programs your organization provides for mental health and/or substance use disorder.
Okay,
I will very briefly reference, because I realized I didn't make this clear in my introduction, that I am also a peer in the realm of addiction recovery. And that informs a lot of my work and my perspectives. So just want to establish that also. But I work for Cornell Health, and we are an integrated healthcare center, which is really nice. So my role as a therapist has the ability to very easily refer someone to primary care or nutrition, or to work with a nursing care manager. The ability to be part of an integrated healthcare system is really, really nice. In terms of mental health and substance use services, we have some ability to treat mental health and substance use through the primary care lens. But primarily, we are working through counseling and psychological services, AKA CAPS, of which I am part of that department. So combination of individual and group counseling, as well as medications provided by psychiatry.
Dr. Sundsmo?
So family and children, in terms of the treatment services for mental health and substance use disorders, we do have an OMH licensed clinic that is providing individual family therapy and psychiatry services for folks who may be seeking support and treatment for those conditions. Our agency has really focused on treating across the lifespan. So we have programs for folks in the 0 to 5 age range and the communities around them, all the way up to our older adults. So really striving to provide the right level of care that matches the services across the age span, and how those mental health and substance use conditions might show up differently in those different types of age ranges. We have traditionally focused much more on the mental health side of the equation. One of the key pieces that I'm understanding as I'm getting to know being an OMH licensed clinic is the drive from OMH to really provide coordinated care for co-occurring disorders. And that has been a steep learning curve for my staff as well. That's a piece that has not traditionally been done in a transparent way, where it's been an expectation of all clinicians to do that co-occurring treatment, but is definitely what we're striving for, knowing that folks coming in, many of whom, if we're not paying attention to it, it's probably just not getting treated. So wanting to make sure that we're wrapping in as part of the same treatment, that this is something that we all can support our clients in being served on both ends of that spectrum. But that is something that has been traditionally, we've worked very closely with our ADC and our CARS partners to really do some joint work. And it is relatively new for our organization to start thinking about proactively treating COVID. So a lot of efforts focused on helping clinicians learn those assessment skills and how to wrap in clinical techniques that complement the work that they've come to know and become so good at, how they can use some of those similar techniques with some added knowledge, awareness, and skills to wrap in our folks who are also struggling with other co-occurring and substance use conditions. We have a variety of other outreach programs in addition to our clinical services that I'd say help with some of the wraparound care. We have our DAP, our program.
Dispositional alternatives program.
Dispositional alternatives program. I'm still learning that acronym, working on it, and our open doors program that many of you may be familiar with. So less from a treatment end, but more from a continuum of care end, as we think about how to support folks. And then soon we'll be working on some additional outreach components related to our 0 to 5 and our older adults that will be a little bit more external facing consulting in the community, as opposed to just the clinical services that we've been providing more so for those populations. So more to come from us in the months to come, but that's a little gist of where we are today.
Yeah. Rich?
I'm Rich Shaw. I work for Tompkins County Whole Health. Still getting used to saying that. I work in the mental health department, and as people may know, the mental health department, the public health departments have integrated, which I think is a great idea. Speaking of integrated care, as was mentioned in my introduction, my position was created. It's been in this county for 20 years. I've been 15 years of the 20 years. And really the purpose of it is to help with, basically the way I see it, you have two different treatment worlds, the world under the Office of Mental Health and the world under the Office of Addiction Services and Supports. And this position was created to help anybody in the county with any guidance around better integrating care or coordinating it. There are clients who are seen in more than one agency, and sometimes what we have is what's called the parallel care, where people are in two different treatment programs, doing good work, but not connecting to each other. And that's one of the roles I can serve, is to get agencies together and do that through in my own department, helping us to learn how to do integrated care. So it brings us to what we do in the mental health department as far as treatment goes. We have an OMH licensed clinic, which I think a lot of people associate the mental health department with the clinic, but the clinic is just one part of what we do. And we strive for integrated care, meaning we address both substance use and mental health issues. There will come a time where we don't separate those out. We're not there yet. And there's reasons for that I won't get into. Jake and I have had a lot of conversations about that, why they're separated. But so what we've always at the mental health department been able to, in our clinic, to provide integrated care, but that doesn't mean people have varying levels of comfort with that. So again, back to those two worlds of substance use and mental health. And I've worked in both of them, so I have a fair idea of how they operate. So we have a clinic. We also have what's called PROS program, and PROS stands for Personalized Recovery Oriented Services. It's complicated, but it's basically a psychiatric rehabilitative model that's heavily based on groups, 12-week cycles of groups for people who have mental health issues and could use help with addressing a mental health issue in order to do things that they want in life. For example, hold a job. So I guess a simple example would be somebody who's having panic attacks may come to a PROS program to be in a group or groups to address how to deal with anxiety, how to get a job, how to stay on the job, we have a vocational coach who helps people on the job. But it's really designed to help people to, they come in with what their goals are. I'm just using work as an example to address the mental health issues that they have in order to do the things, to be as independent as possible in the community. It wasn't that long ago where there was something in our department called continuing day treatment. And that model was just about like, come to us and socialize there 5 days a week if you wanted to. And so fortunately, the Office of Mental Health changed that philosophy and said, let's help people. And they use this phrase, it's PROS is something that people go through, not go to. So don't go there to just be there. You go there to achieve whatever you want in the community. And it's really grown and changed over since it started. I helped get it started by creating some of the groups. The groups change in a 12-week cycle based on what the population is in PROS. So there's a large library. When it started, there was no library. Now it's a large library of group curricula, which is mixed and matched depending on what the population, what the assessment is of the people who are in the PROS program. So it's an ever-changing 12-week cycle of groups that people can go to meet their needs for psychiatric rehabilitation. We also have a mobile crisis team, which is a 24-hour-a-day on-call person. After hours, it's actually two people. There's a primary counselor and a secondary counselor. And the primary counselor takes the call, and the secondary can back that person up if the person's on a call and the second call comes in. There's also what are called, this is a very new, there are two care teams, and care stands for Crisis Alternative Response and Engagement Team. And what the care teams are, one is a social worker with who pairs up with an IPD officer, and another team where a social worker pairs up with the sheriff's deputy. And they go out during the day and intervene, ideally pre-crisis. They work in concert with our mobile crisis team, but they are out in the community doing face-to-face interventions, in some cases following up on crisis calls. So they attend the mobile crisis team meetings that we have every week. And we get their input and work very closely with them. We do other things.
Can I just?
Yeah, sure.
I just want to make sure we have time for all of our questions. I'm so sorry.
No. Those are the main ones.
Let's circle back to those other programs through your answers to the next series of questions, but Samantha, can you go next?
Sure. Reach Medical is a low threshold harm reduction outpatient facility. We're licensed by OASIS. We have a large addiction medicine service program. We serve about 2,200 patients for Suboxone in Tompkins County. We also have fully integrated primary care and acute care, along with fully integrated behavioral health, both counseling that has a specific focus through 3 full-time CASEX on substance use only. And then we have 2 social workers that kind of expand their scope into just therapeutic services. We have a full-time psych NP for psychiatric medication management. We actually just hired 2 more full-time psych NPs that are onboarding right now. So that's great news. We're looking to expand into women's health, specifically for people who are pregnant and in active drug use or have historically been in active drug use. We have an outreach team that's comprised of 11 full-time employees, and that's a blend of nursing staff, community health workers, and intensive case managers. So they kind of meet people where they are out in the community. They can mobilize vaccines, Hep C and HIV testing and treatment. Am I forgetting something? I'm definitely forgetting something. Primary care. I think that sums it up quickly.
You'll have more time to circle back to anything you may have forgotten.
Yep.
Turning to you, Jasmin.
Yeah, Hugo Addiction Recovery Services currently has a men's residential program in Trumansburg and an outpatient opioid treatment program licensed by OASIS. We work with clients as young as 14. Coming soon, we will have an additional Cortland site, which will be an opioid treatment program and a mobile methadone unit scheduled to get out to places where there is little substance use treatment like Norwich. That's out by like past Cortland. Our vision is to build a stronger community through innovative addiction recovery services, one life at a time. We also aim to transform lives in the community with flexible and inclusive person-centered treatment. Our core values are belonging, transparency, and kindness. So the outpatient opioid treatment program in Ithaca is the clinical site that I personally work at. My job details are I work directly with the client. So I do assessments to see if clients meet criteria for substance use disorder, individual counseling, group counseling, family counseling, referrals to detox and inpatient, working with the court and other legals such as misdemeanor, felony, family treatment court, probation, parole, CPS, and the DMV with the DWIs. I assist clients with their goals for substance use, mental health, legal, vocational, educational, relationships, among other goals specific for the client's needs. I also train other clinicians on these practices. We also have a continuing care program to keep clients active for them, to kind of keep an eye on them, to check in and see how they are doing. They just have to check in once a month. They can meet with a peer, counselor, nursing, and we kind of address their stability and if they need to come back to treatment full time. We also have a medical provider who provides medication-assisted treatment and can treat hepatitis C. Medical staff also participate in free Narcan training presentations throughout the community. We have 2 peer advocates who are in recovery and help clients with navigating resources they may need. CARS also provides methadone to the Tompkins County Jail, Cortland County Jail, and Elmira Prison.
Thank you, Jasmin. And if you could keep your Zoom unmuted, I'm going to have you kick us off with the next question.
Sure.
So can you describe what trends you have seen in the last year or 2 in the local community for those struggling with mental health or substance use disorder?
Yeah, I think I'll start with a positive trend. I have seen a lot of preventative measures being taken by people in the community for overdose awareness. A lot of people have Narcan, and we also give Narcan here free. I know they have some at STAP down the street too, but And we provide testing strips for xylazine and fentanyl testing strips. So we have a harm reduction standard that seems to be, helpful to the community. As I know the other panelists have their things that they use too. But as far as some stuff that it seems like trends that people are struggling with, I think housing is always a huge one. There's a lot of people who are homeless and using and have mental health issues that don't have the ability to just automatically get into housing, especially with the long wait list for Section 8, things like that. As far as substance use wise, it seems to be an increase in synthetic cannabinoids, which is also known as K2 or spice, which are those herbs sprayed with powdered chemicals that are usually mixed with solvents. They do not come up on a standard drug test. So we see a lot of court participants using K2 while they're trying to get through their legals. We can test for K2 here, but we have to put it specific on a lab order. And there seems to be a big methamphetamine use increase. I don't know if that's just because people are no longer using just opiates. That seems to be a huge trend that's increased. And marijuana use, I know there was questions regarding youth, and I think marijuana use has been an issue in schools because it's legal. And it does not mean someone involved in court can't smoke it. So it seems to be popular with students vaping. I have a colleague who has a student or has her son goes to Lansing High School, and she said that they just sent out a huge email about students vaping in the bathroom and like how they can be preventative for that. So it seems like that's kind of getting a little bit more out of control there. But yeah, that's what I got.
Thanks, Jasmin.
Thank you.
Turn it back to Samantha.
I would say we've definitely seen an uptick in just the term alone of harm reduction. It's become a buzz phrase. I think there's a lot of misconceptions about what harm reduction is. Some people believe that harm reduction is just doing whatever you want and having no consequence. So I think for REACH as a mission-based organization that really kind of loudly says we're a harm reduction agency, I have been asked to present all over the place to all different kinds of agencies and just talk, which I really appreciate because we're able to spread education around what harm reduction is and what evidence-based prescribing looks like for people that are living with opiate use disorder. I would say from the medical side of things, we have unfortunately seen an increase in both fatal and non-fatal overdoses. I think we could all agree that this is because of the presence of the man-made fentanyl that is now in basically all substances that people are using. We've seen in our patient population, patients that have been in our care for many, many years that are known and very transparent about using meth only. Their drug tests and their urine drug screens are now coming back with no methamphetamine at all. It's just fentanyl. Fentanyl has kind of taken over every substance across the board. So there's been a big increase in fatal and non-fatal overdoses. Additionally, I would say on the medical side of things, we've seen an increase in non-healing wounds and in antibiotic resistant wounds. This is being attributed to the presence of xylazine along with the fentanyl. The xylazine is having really bad outcomes for people's skin in regards to the wounds and the non-healing wounds. So we're kind of like in this walking this very fine line with a lot of our patients that are living outside, refusing to go to the hospital, refusing to get IV antibiotics, and we're treating the best that we can. We have case managers and we do have an addiction medicines provider that goes into CMC and is contracted for addiction medicine services. So she kind of tries to bridge that gap when people are admitted and it's on our radar. But we've seen a lot of increase in those types of wounds. We've also, of course, to echo, it's a lot of homelessness. We've seen a big increase in homelessness. On the contrary, there has been more supportive housing that has opened up for people that experience chronic homelessness. I think for our organization, because we are the largest stakeholder in providing outreach services to people that are experiencing chronic homelessness, we've seen a huge uptick in evictions. I would say TCA probably is the exception to this, but all other, supportive housing authorities have quickly and swiftly evicted this population after they have gone through all of the hoops and worked really hard with our case management team to get housed. So unfortunately, we've seen a lot of eviction come with them being housed. I think that's it. Samantha?
Yeah, and I'm seeing some of the same things, so not to repeat those, but what I will add on to is that housing for people with what's called serious mental illness, and that's a term used by the state, and there are criteria that people meet for that, that are set out by the state that people need to meet in order to be considered serious mentally ill. It's a long story. But I'll leave it at that. But they are afforded special services in this county. And to make a long story short, housing is a real issue, always has been. Long waiting lists for special housing, special supportive housing under the Office of Mental Health. And I'll just give an example. There used to be 2 community residences where people could live in a residence in a shared space with other people. We only have 1 now, and that had to close down temporarily. It's slowly reopening. But for people coming out of psychiatric hospitals, out of substance use rehabilitation programs, how to get housing that has built-in supports so that they have the best chance of staying well is really in short supply here. And there are long lists, and so people can wait for a year or more to get this very specialized housing. And for me, I'm always, concerned about what's happening to them in the meantime. Where do they go? And sometimes it's so-called couch surfing, or living on the streets, or living in the shelter. So housing is a real issue for the most vulnerable among us with substance use and mental health issues.
Thank you, Rich. Just to take a different approach, I would echo everything that they all have already contributed to the conversation. I think another trend, just as we think about services and access to care, is around the changing nature of telehealth care, what it serves, what it doesn't. In 2023, it was late spring, early summer, OMH came out with some telehealth guidance and standards of care. I think what we're seeing in the field is we're seeing some shifting demographics as people have access to telehealth care, particularly those family and children's has served a wide range of folks with a wide variety of insurances, but with the increase in telehealth access, folks with better insurance plans who can get access through Headway, who can get access through a broader network across the state, changes then who needs our care and who fits within certain demographics. So we're seeing some differences in terms of who we serve over time from what would have been pre-COVID times when folks did not have the routine access to mental health care. And now as we sort of start to think through what telehealth actually can do and do well versus when it's not appropriate, I would say there's not good public education about the difference, right? People just think about it as an accessibility issue and not about the clinical appropriateness of one method versus another. When is this actually working for my treatment? When is it not? And there's a lot of confusion, I think, both among consumers of services as well as providers of services about navigating those lines as we sort of think through that. And I think it has shifted to the nature, I don't know, I'm assuming you all are seeing this too, but it shifts the nature of who we can best serve and what our place is in the broader community as we think about who does not have access, right? We increasingly become the only place a sector of the population can go and are seeing that change the nature for our caseloads, right? As we used to have clinicians who see a wide range of clients, right? Many of those with less severe symptoms, with better insurance, with more resources, are now going to other telehealth providers, which means we have more case management needs and other things that we haven't necessarily kept up with and built, anticipating this
shift in the overall marketplace. So I think just to kind of give a different angle on a different trend, that would be another one I'd highlight for the group.
Dr. Sundsmo.
Sundsmo.
I will echo all the things that these wonderful people have said. And I'll narrow in on my population. We work exclusively with Cornell students. So that is the demographic that I'll focus on. For that age range, transitional age youth, I want to acknowledge the impact of the pandemic. The folks who are graduating this year were the folks who missed their senior graduation because of quarantine. So we have seen a big impact from people having extended periods of intense isolation and varying degrees of re-exposure to being part of the community during a critical stage of psychological development. So we see a lot of people who are chronically lonely, I would say, and really struggle with interpersonal relationships. That's a regular theme impacting the mental health of our young people across the board, and certainly Cornell students. Connected to that, I've seen I would say an increase in other addictive behaviors that are not even just substance use related, but other things that are part of emotional self-regulation in isolation, like gambling, like pornography, like social media use, just to expand the conversation about addiction beyond just chemical dependence and substances. In terms of substances, I have seen, I would say, a gradual increase in Adderall misuse. I'm seeing more ketamine use. And certainly with the increasing access and availability of cannabis products and edibles, more related to that. Each semester, I'm seeing more hospitalizations related to edibles. Some of our dispensaries sell products like a Twizzler that's 100 milligrams of THC, when just for reference, like 5 to 10 milligrams is an average normal dose for someone who uses periodically. So the fact that it is not a regulated market, I think, is causing a lot of harms. And whether it's the folks who use once and end up having a panic attack and needing to go to the hospital, or the folks who are falling into a trap of regular daily use, because it's still very much the cultural interpretation that you can't be addicted to weed, even though it's a very different drug from what it was 10 or 20 years ago, as the plant itself is being bred to be higher and higher concentrations, and there are all these tinctures and other products that are just skyrocketing. Go on, but I'll pause there.
Well, I'm gonna give you a chance to go on right now. I'm gonna start with you again. This next question, you could answer both or just one of them, but they both relate to gaps and barriers. So part one of the question is, what gaps or barriers are you finding with your clients and that your clients share with you in terms of getting the care they need, or any barriers they're experiencing? And or you could talk about barriers that you're experiencing when you're trying to provide assistance to your clients.
Okay. I'll try to touch briefly on both without taking up the rest of our time. In terms of gaps in the organization or systemically, when I first came to Cornell Health, there really wasn't any substance use treatment. It didn't exist. The policy was that if someone came to Cornell Health disclosing concerns about their substance use, they might get a session with one of the therapists who would pitch why they should go seek treatment off campus at ADC or CARS. And that was basically the extent of it. But Cornell Health was very clear with the boundary that they did not treat substance use disorders. I have very strong opinions that is unethical, both because of my lived experience with substance use, as well as just the awareness I have of our community. The population of the city of Ithaca is roughly 30,000, and the population of undergrads at Cornell is 15K plus. So during the school year, about a third of the people in Ithaca are Cornell students. So to expect that within a population where substance use disorders are prevalent, that there's going to be an automatic withdrawal campus policy is just not sustainable. So since I've been there, we've initiated standardized screenings at both medical appointments and CAPS appointments. CAPS again being the acronym for Counseling and Psychological Services. So someone's substance use is being measured in some ways or coming in the door. And over time, working on increasing the proficiency of providers to recognize how their substance use may be intersecting with other things that they're asking for help for. I think it is very common for most providers to say, are you concerned about your substance use? And someone who's actively addicted probably isn't concerned about their use. They're thrilled because it's the only thing that makes them feel good, but they are concerned about the fact that they can't sleep, they can't focus, they're really depressed. So going deeper to that conversation, not just are you concerned about your use, but can you see a connection between the fact that you aren't able to get any of your schoolwork done and you're smoking weed a couple times a day every day. We now, as a result of that screening process, we now can offer someone to meet with not just a substance use treatment provider, but we pitch it as, would you like to meet with a therapist who specializes in the treatment of co-occurring mental health and substance use disorders, because we're very big on co-occurring treatment. Thank you, Rich. These people were both my supervisors in my career, so thank you very much. And to be able to integrate the awareness of how someone's substance use is impacting their mental health is critical and really big. Because there are regulations around the confidentiality of health records involving substance use, people have the opportunity to either opt in or opt out of substance use treatment. And if they've opted in, there's an extra level of protection to any records involving substance use treatment. And if they, on our release procedures, they can select to exclude any notes from their substance use treatment when they're sharing the rest of their medical record. So if they want to share everything else with somebody and exclude substance use treatment just for the sake of making it feel safer and dealing with stigma, that is an option they have. So individual counseling. Sorry, I'm going into the services that we offer instead of just barriers. I think I touched on some of the barriers. Stigma is definitely a really big thing. Nobody wants their professors or their parents to know. A lot of students walk in the door thinking that by default, I'm going to tell their parents that they did cocaine. That is not the case, and I'm still trying to educate around that. And then education among our providers in-house as well as the community at large. I think it's just, not putting any individual provider on blast, but it has just not been common practice to integrate substance use treatment into mental health treatment. So, recognizing that if you can see in someone's chart that they had a concussion recently, it's probably a good idea at the point where the medical provider is talking to them about their concussion that they're reminded that it isn't going to help them if they're drinking. I've seen a number of situations where someone gets a concussion, that conversation isn't had, and then there's some interface with CUPD because part of a concussion means issues with impulsivity and emotional dysregulation, and that coupled with heavy drinking is going to lead to problems for kids. I'm rambling now, but I'll pause.
Thanks, Jacob.
I'll highlight a gap in services in our community, which is the need for intensive outpatient care. I am frequently, as I'm sure others, receiving at the outpatient level, folks who are not appropriate for an outpatient level of care who need more and will not be able to make the gains that they need, whether that be in mental health, substance use, or a combination thereof. And the need for that ability to do that, again, given the changing nature of the population we are serving, there is this rise in telehealth IOPs, which are wonderful and amazing in getting access to care but it is a two-tiered system for folks who have the insurance who will pay for that. And our folks with our Medicaids and our Medicares are really struggling to find access to that level of care. And so I am frequently on the conversation with our lovely social work colleagues at the Cayuga Medical Center when they have somebody to discharge who they think needs to come right back to me. And I'm like, they are not, we can't, this will not change. This will result in a return to your facility and often does end up in multiple hospitalizations because we can't get folks the care that would actually get them better. And there is really good research to show that the more intensive, more quickly getting that involved, getting them that higher level of care from a prognosis perspective does a world of good in terms of their ability to sustain. But if you continue to under support and under treat, you're actually reinforcing and making that prognosis worse, right? It's sort of like you're taking, if I would use a medical example, which maybe is a little dangerous, is like taking half of your antibiotics, right? Like it's not helpful to take a lower dose of the thing that is not the right treatment. You need the full dose of the treatment to really get better and then see that. And instead what happens is there is no other care. So the idea that some care is better than no care is a challenge, right? And so we really have this gap in this intensive outpatient or sort of higher level need for services in our community across the board of different age ranges, of different presenting concerns. We've got some major gaps that are leaving those of us who have to serve by a regulatory standpoint, these clients knowing that full well, this is not what it's going to take to get this person to a different space. And that's not fair to our community. So I'll try to keep it short so we can move on to our other colleagues.
Yeah, one gap that what you said makes me think of it is that, well, because I deal with it, is that people can be very mentally ill and live in this community and not be helped unless something bad happens. So a big gap is, so somebody could be an adult, could be living in an apartment, being taken care of by family members, be psychotic to the point where they don't even know who they are or what day it is, or who their parents are. And as long as they're not reaching a threshold where somebody can intervene, they can live that way indefinitely until something bad does happen. So there's not really, we're working on it, I think, in this county, but there's not really a way to intervene with people at that level of illness until something happens, or we, the county can show that they're at such, what we can do is have them transport up to the hospital. It doesn't mean the hospital is going to admit them and they can be back out on the streets within a few hours in the same condition or worse. So I think we, as a community, really need to come up with a plan. There was somebody whose elderly parents came to me to help their adult daughter who was just living blocks from the mental health department. And she was so psychotic. Like I said, she didn't know who she was or where she was putting herself at great risk, and I'll get into all the details of that. And the parents lived in another country and were just living with her to try to get somebody to help. They went to a number of different agencies, including ours, and were told, like, there's not much or anything we can do in this situation, basically until it gets worse. So long story short, I did sit down with my boss, we made a plan and went to see her personally and started to coax her into the mental health department, which she did come, but there wasn't services, there being, with the care teams and other services, some of those gaps are starting to be filled. But it's going to take a while before people who are living out in the community who are so mentally ill can more easily get help in a preventative way where it doesn't have to get worse before it gets better. So that's a big gap.
I would say that it feels like there's also a gap in community education of resources and what those available resources are. I think unintentional silos happen for a number of reasons. I know from a service provider standpoint, you're burnt out, you're way over capacity, you're working within a model that doesn't fit the system. You're providing the services that you can provide, and your colleagues down the road are doing the same thing, and you're not totally aware of what their reality is. Funding doesn't allow you to expand in a communications or education type way, because you just have to stay focused on patients, and that's really all you can sustain. So I think unintentional silos happen with this lack of education and communication, all the way into court systems, IPD, the hospital, other health systems, doctors' offices, it kind of transcends in our whole community. There was a patient, Tompkins County resident passed away last week, and he was a person that, has been in care for 6 years with us and was statistically very high risk. And because of the gap in low barrier shelters, he died. We were begging DSS to move his appeal date up. We're begging the shelter to do something, and these systems make you check these boxes. And if you're not able to check them, or if you can't just wait and sleep outside for another 2 weeks until you can go and plead your case, there's nothing available. So there's no low barrier shelter system for people. You will absolutely get left behind. Even if you're statistically incredibly high risk, a danger to yourself or others. So the whole low barrier shelter system is just non-existent in our county. I would say from a provider standpoint, it's really difficult for all of the reach providers to meet patients, even having as many integrated services as we have with primary care and acute care and behavioral health and psych med management and all the things. Providers are meeting with patients who have such complex and vast social determinants of health needs. Even with a fully loaded 10, 11 full-time case managers and outreach workers on staff, it's not nearly enough. People need liaisons to talk to their landlords. They need help with everyday things, and in order to not have bad outcomes. And those services and we try, but we have definite capacity issues in that way too. And I guess lastly, this is kind of talking about what we were saying with the prescribing and taking a lower dose. And I think there is a lot of stigma around buprenorphine prescribing, methadone prescribing, psych med management, things like that. Even from pharmacists, they're calling and saying are you sure this person bought needles? And we're like, yes, they still deserve their psych meds. Please dispense them. So there's a lot of stigma at different levels of care too, outside of our own practice. You see them and you treat them and they go into the world and they're still facing all of these other barriers that are not in your control.
Jasmin, back to you.
Yeah, I definitely agree. Stigma was the one thing that I put on number one here. Because the clients feel like they cannot open up about their use or address it in situations due to feeling shame or guilt, or they have never had someone in their corner fighting for them or wanting to help them while being non-judgmental. So everyone's situation is different. A lot of clients feel like they are being put in a box of who they are, what they've been through. And with the housing and mental health services, there's continued substance use in housing programs. Despite, trying to help people who are homeless. So clients in environments where people are still using, it's hard for them to focus on their recovery. It's tough. And I think that coincides not having a lot of structure. Some clients come from prison or jail where they had structure, but were very limited in resources and what they could do. So they come out, have no real direction. Ideally, they would start all the programs necessary to guide them and assist them, but not having those set up upon release is hard to continue to get these clients reintegrated in the community and learning how, not to go back to jail or prison. And then as far as personally, here for our staff, alcohol and drug council closed 1 or 2 months ago. So we've had a huge influx of clients. So that can obviously lead to a lot of burnout. Our caseloads are very high here, and it's hard to give, people the kind of what everyone else is saying, the individual care that they may need. And then of course, the lack of resources in general. Just the influx. It just seems like the chronically homeless it just continues, and then it's hard to keep up with that. So that's what I had.
Thanks, Jasmin.
I have more questions, but I want to pause and allow our guests and board members to ask some questions and reserve the last 5 for my final question. And that was terrific. Thank you so much.
Chris?
Thank you very much. That was super interesting. So I think a lot of people in this room were involved in non-clinical human services, educational organizations and programming. I think it'd be super interesting to hear from you all what it is you thought organizations like ours could do to better support the clients you're working with, because there's a lot of overlap. We work in probation, we work in parents apart, we work in parenting programs, we work in a whole range, we do referrals programs. But what is it that you would like to see in the community, that sort of non-clinical environment, that we could, as a community, discuss and formulate and implement to support the folks that you're working with?
Anyone can answer.
I mean, I can answer if you'd like.
Please.
Okay. Sorry, I had to be on Zoom. I work with clients, so I was like back to back to back. But yeah, I think that the biggest thing for everyone is just communication. What you guys do provide, maybe getting information, like everyone, like you can have like my email or someone's email, just because if we have that, we can know what we can reach out for you guys, and then we can kind of like make it a dual relationship where we partner and get things done together.
And to add to that, just being aware of what goes back to some things Samantha was saying about just aware of the services. You know, I don't think there's a day that goes by where somebody's not aware of something like care coordination, that's available and how to access it and what it does. So a lot of services, this unintentional siloing, I think breaking down the silos so that you know what services are available and how to connect people to those services. Because people sometimes are left to be their own coordinator of services and to figure things out for themselves. It's such a complicated system. We have a lot of riches in terms of the services in this county, but there's a lot of complexity to it. And many people who need services just can be overwhelmed, including staff. Many of our staff are overwhelmed with to go to how staff are being affected. I think the systems are overwhelming to the staff. So just to use an example, so somebody who is facing homelessness or is homeless, a staff person who's providing mental health treatments, how do I provide mental health treatment with somebody who's living out in the woods? You know, I need to help this person to get housing. Where do I start?
Reach.
Yes, well, yes, we do. We have speed dial. But yeah, what services are available? How do we connect people to those services and develop relationships, like Jasmin said, with those resources, those agencies?
One thing I'm thinking about is like in an academic setting, one of the things you talk about a lot is universal design. And I would love to see us think about that from a community standpoint. What does it take, knowing that we have, I don't know what the latest stats, depending on your age range, roughly a third of folks with a mental illness in any given year, right? They all have to use the grocery store. They all have to use all of the basic services that the rest of us use. That I think from a human services, from a non-clinical treatment perspective, what would be amazing is to think about how do we as a community build one where folks with mental illness, separate from their treatment, right? People have the right to get treatment when they want to, not get treatment when they want to, think through that, right? Regardless of their treatment needs that we're serving, how do we build a community where they can thrive? How do we build a community that raises awareness about who's in our community, who's a part of it? What was the little sticky notes, right? Who's in our community? Folks with mental illness and addictions of all sorts and kinds, right? How do we build this in a place where they are welcome, where they are seen, where they are heard, where they can be in storefronts and businesses and their landlords can have some understanding of how to negotiate when there are issues that arise? How do we build that overall community sense of universal design and that all folks can thrive? Because there's critical components that have nothing to do with treatment, and treatment needs to be a choice if and when folks are ready, but they need to be able to live their lives, and their humanity matters. And I think that's where the human services, from my perspective, could play a huge role that I can't play. I will never touch that in my clinic, but I have to deal with that outcome when they then can't engage in the community around them, which ultimately hurts their treatment. But regardless of that, I'd love to see you all take on some of those initiatives and think about building that community.
I echo that strongly, yeah, you know, because it does feel like from a service provider standpoint, all of those barriers and problems and challenges fall onto us and our staff, you know, you're unable to treat people that haven't eaten in 2 days. You know, we're unable to treat people that don't have shoes. And so we're a nonprofit, trying to figure out who will donate a pair of shoes that are the right size for our patients so that they can walk down to their DSS appointment. And just this baseline, and sometimes it takes hours, you know, sometimes it takes hours. So like posting on mutual aid and we're paying staff to, you know, licensed clinical staff to do these types of things. So, because we just don't have enough of what you're talking about for it.
Sure, yeah.
Can I answer that question quickly? I really appreciate the question, and my response is going to be first to warn you to ask for something that I think is pretty hard. And that's to challenge stigma, not just in a professional context, but day to day in your own life. I worry when we talk about challenging stigma that it comes across sometimes as let's just be nicer to those people who struggle with mental health and addiction, rather than regaining insight into how we all exist on a spectrum of mental health and substance use issues because they are human experiences, right? I would not have wished for the impact that social media and technology has had on the mental health of our young people, but I think one unintended silver lining is that a lot of people have an embodied intuitive awareness of what it means to not have full control over your behavior. Most people have at some point experienced, oh, I don't remember pulling out my phone, but my phone's in front of me, or absentmindedly scrolling and thinking, I really wish I could put this down. I really wish I could put this down. And that's a little taste of what it is like for someone who is living in active addiction. So my ask would be, not just that we're thinking about professional interventions, but are you thinking about how your caffeine use may contribute to your anxiety? Are you thinking about how your sleep is disturbed by spending too much time on technology? And are these normal conversations that you're having with other people in your life? Can these be normal parts of how we interact and love and support each other so that we're actively protecting each other from sliding into a space of poor mental health and addiction? And when we are having conversations with people who are deeper in it than us, we have a greater capacity for empathy because we've been thinking about it.
And you can, there's training out there, and I don't know what Jake thinks about this, but things like mental health first aid, where you're not a clinician, but and I think people who are non-clinicians aren't sure what to do with certain behaviors, and mental health first aid. And there's other programs out there. It's a one-day training, which gives you a pretty good overview of how to intervene in any number of mental health and substance use related issues. It's really good training.
Totally support mental health first aid. The Mental Health Association in Tompkins County offers it. They're great. I used to work there. Great job. Yeah. When I am working clinically with somebody, some of the things that I am most excited for is if they have a partner or a family member who gets it, that they feel safe talking to about what's happening. I recommend things like, I think people who haven't experienced addiction probably don't realize how hard it is to turn on something on Netflix and not see someone drink for the sake of emotional coping. You can't just watch a show. You can't go hang out with friends on the weekend without substance use being part of it. And unless you're looking for it, you probably aren't noticing it. So I just invite that mental exercise, start trying to look for it, not in ways that are obviously harmful and destructive, not ways that are at the crisis point that we're having to figure out how to react to right now. But what are each of these steps of normalizing the use of the substance for emotional coping that are actually getting us to this place?
Okay.
Off the soapbox.
Question from Frank, and then I'll also look to the Zoom room for questions after Frank's.
You folks do an amazing job with what you have to provide. And you're right on the front line. The state budget just passed. Is there anything that came out of that budget that's gonna cause you to readjust some of the programs or the accessibility that you're able to provide now, either positively or negatively? Did something happen that is gonna enhance your ability to? We're always looking for more resources, don't get me wrong, but sometimes it doesn't work that way. Is there anything that will impact your ability to deliver the services you're able to deliver now? Anybody?
The state budget, unfortunately or fortunately, doesn't directly inform our budgets or reaches budget all the time because it has to go through many channels, right? And then ultimately, I think a lot of times it lands in a county bucket to be decided. I think funding in general for service providers in this line of work, can be really tricky because these pots of money get put out and like earmarked for service providers. And then a solicitation comes out that puts us all in direct competition with each other. Instead of helping us work together, because we all have to be strategic on like how to survive and maintain our model and deliver good care, but also keep our doors open. In our experience, there's never been enough money available for an organization like ours that's providing care to almost 90% Medicaid recipients, because as we all know, Medicaid doesn't even reimburse the cost of services. So all that is to say it's tricky. Unfortunately, the New York State budget, drastic changes will affect us. There's none that I know of right now that we're expecting to come down. But as far as funding opportunities, oftentimes I think they unintentionally kind of put us in competition rather than collaboration.
Any of the other panelists like to answer that question?
I can answer a little bit. I agree. I think that we are a non-for-profit as well as Reach, so we don't get a lot of state funding that I'm aware of. A lot of it is just grants, to be honest with you, like this mobile methadone unit, and that opening soon is because of a grant that was written. So as far as state funding goes, I'm not really sure either. I guess I'm on the same page as that.
Think of anything that's coming down from the state that caught my attention is really
Yeah.
changing.
Wasn't much that time. Thank you. Other questions, or let me look at the Zoom room. Are there any questions from our Zoom participants? Back to this room. Oh, that's
So folks, with the onset of COVID many years ago now, folks are becoming incredibly intentional with how they spend their time. And I know that there's been a shift in young folks entering mental health and substance use fields. I guess my question is, what would you say to those young people who are hoping to enter the field so that they can be most supported from burnout and or through burnout?
To learn to take care of yourself. It's so easy to get caught up in trying to help somebody else. You're not taking care of yourself. I work with interns when I have when opportunities come up, and that's self-care is one of the main focuses that I address with them. And one of the things I say to them is, if this is stressful for you, then I'm doing something wrong. How do you work in this field and handle the stress in a way that you stay well? And if that's not happening, if you're not well, it's very hard for you to take care of somebody else. So self-care is really important.
I totally agree with that. I think being very intentional about cultivating a deep awareness of what you need to be well is critical. Self-care and also community care. Like find people. None of us are an island. There's community out there if you look for it. I took my mom shopping on Mother's Day yesterday. I asked about how to take care of this bonsai tree, and the guy behind the counter told me that there's a Finger Lakes Bonsai Society that meets once a month on Cornell campus. So I'm about to become a member of the Finger Lakes Bonsai Society. You don't know where community is until you're looking for it, but find people. There's more and more push for us to be isolated. We have to be, I'm gonna say, aggressive about finding people.
One thing that I'll add, there's been a lot of efforts, particularly to recruit, because the mental health field has not had a diverse representation of folks to match the clientele that they serve, generally speaking, writ large. That there's this increasing pressure that many young mental health providers, particularly of color and queer providers, are coming into the field with this desire to serve their own, which is wonderful and risky. And so one of the things I might highlight specifically for those folks is thinking about the sense of responsibility one feels for serving those populations, that there often is this ask in many agencies that you then take on your community, which you are not likely trained to do, right? And so again, just an example off the top of my head, oftentimes folks with language skills will get pigeonholed because they're the only one who speaks that other language in their agency, even if their model of clinical training doesn't fit the client and their orientation, right? And they have no experience with that particular condition, but they speak the language. Therefore, healthcare provider, please treat this person. This idea of sort of, and clients also are looking for this match without thinking about that somehow that cultural knowledge will transcend the healthcare aspect of what somebody's been trained to do. And while there are some elements that may, it's not the same. So I think we have some unique risks and unique opportunities to support. We need them, we want to cultivate them, but we will 100% burn them out if they feel like they're taking on the responsibility for the population from which they come. They also have all of these added layers to work through when they're in the work, right? Not only of the sense of responsibility for community, but it's going to pull on some, forgive me for using some clinical terminology, but some different kinds of transference and countertransference that are related to some of those cultural identities. Sort of what they are looking for from you is no longer just about you as the clinician. It is you as a woman of my background or as a trans person who should know better, right? Like there's all these added layers to expectations that are different than what other healthcare providers are being asked to do, either from their agencies or from their clients or from their peers to educate them, right? And so I think we have some unique opportunities with those up and coming young professionals to try to find some mentorship relationships of folks who've navigated some of those added layers, some of the added layers, particularly in a small town like ours, as they relate to finding community when the communities are already so small. In pockets, particularly as their identity related, to think through how can we uniquely support those folks so that they don't burn out. Because I think it's additive, right? In addition to facing some of the same, racism, homophobia, transphobia, et cetera, that are also navigating in the world, right? Really want to support those folks in finding their way here and building sustainable careers in the field. So I think that's another area where we could do a better job of mentorship, particularly in agencies paying attention to the added emotional labor that folks are putting on.
Sarah, we did get a question. I don't know if there's time. We get a question. It says, are any of your organizations collaborating with Ithaca High School or BOCES counselors to better educate teens and address substance use issues earlier on? What can parents or caregivers do to help teens?
Matter, that's my take on it. We are involved, one of the things I left out, I'm trying to cover everything in the overview, but we do treat children and adolescents, and we are in 6 schools, the mental health department. From my sense of it, this is where I get in trouble, giving my own opinion, but I don't think we really focus well and catch substance use issues early on. Just doesn't happen for a whole bunch of reasons, which I won't get into. So, I often say to people, somebody who has a severe substance use disorder, it didn't happen yesterday. Often some of the severe substance use disorders have their roots in very young age. And I think there's opportunities to really intervene and to offer help and to listen to people and really hear why they're using, for example, listen to someone non-judgmentally. And I'm not sure that's happening. I don't hear of it happening.
I also think the education piece for young people is really important. Reach has been attempting to do some Narcan trainings and, the presence of fentanyl and specifically for the younger population, the school age population, around the pressed pills that look exactly like Adderall and they look exactly like the Xanax, but they're a lethal dose of fentanyl. I think there is lacking education around that. Reach has not been welcomed into the local schools for that training. We continue to try. I think there's some bureaucracy issues that are occurring. But it's always on our radar, but I think the education piece for the school age kids is really important. Because it's a reality. It's taking young lives.
I learned it better together, actually, that 513 just started a teen substance group. but it's
Yeah, I
open.
have it right here. I wanted to show you guys. I don't know if you can see it.
There it is. Cool.
It's Teens Unite. So it's at 518 Tuesdays from 4:30 to 5:30. It just started on May 7th. So they have that for teens now, which is amazing. Yeah, I just want to show you guys the flyer. So Tuesdays 4:30 to 5:30 at 518 for teens.
So we have about 2 minutes left. Any parting thoughts, like 30 seconds of what you want us to remember before we leave today? Something you didn't get to say?
I think it's a big issue.
Second that. Low barrier housing first.
Just listening to somebody can greatly change their day and their perspective, even if you don't have an answer, just listening.
Community care is mental health care. Community care is addiction prevention.
This was amazing. And I think you gave us a lot of little threads to pull on, like little teasers of like, I can't really talk about this more, but you raised a lot of really great questions and I just want to give you a round of applause. Thank you so much. And
Thank you.
sorry. Our next meeting, forgot that I have this role. Our next meeting is on June 10th and it will be via Zoom. And is today the tour?
Yeah.
Okay. What, do you want to talk about that?
Sure, if anyone is interested in staying for a few minutes, I can walk you through the new mental health unit. It's right here on the ground floor. So happy to do that. If anyone is interested, I'll just be out in the lobby. And don't forget to put a post-it up if you're able to. Greatly. Thank you.